Okay, I think we're ready to go. Everyone, welcome to the call. If you want to put your name and where you're from, you can in the chat, even though this group is well known to us. And it's nice to see some friends, longtime friends. Hi, Linda. I can't not call out Linda. It's nice to see you, dear one. So we're super excited to kick off what we're kind of calling a mini sprint for fall 2023. Usually we begin our cadence for build for a fall session in August so that we can have a full 4 months of public build per our usual process. We have a short session this time because of the delayed start of our digital inequity and digital access, digital literacy domains. And so we're going to be leveraging this time this fall to do some level setting on some pre-work we're doing with Coding for Food. And they will present this to us and really leaning into some enhancements, readying the ecosystem for the inpatient quality reporting, screening for social drivers of health measure. And we'll go more about that into the slide in the next slides. But welcome to the September 2023 call. We're super happy to have you here after our very, very short August break. Next slide. So thank you for joining. We mute you upon entry. And then particularly in this call, we tend to be really good, or I try to be good about working the chat. It is a tiny group of terminology-minded folks, and so we are a collective of friends by now. So if you have things to say, just stop the train and we'll keep on going. Right in the chat, send your chats to everybody just so we all can see it. And as always, the recordings are available on the Confluence after the call. Next slide, please. This is the Common Gravity Project Antitrust Practices slide. So any Gravity Project participant has the responsibility to comply fully with federal and state antitrust laws, as always. Next slide, please. I'm really super grateful for our 2023 project sponsors and partners. We've had a very successful year so far, really just based on the support of our members and sponsors. So thank you so much. And this includes in-kind sponsors because there's been a lot of really significant in-kind support over the course of 2023. If you ever have any interest in becoming a sponsor for 2024, you can always find links on the Confluence or send information to gravityproject@hl7.org. Next slide, please. A little bit of Sarah, a little bit of not Sarah on this one. So it goes through some announcements, go through project schedule and overview, which is important because we are suggesting a little bit of a shift of cadence, and we'll talk about that. Some of you who were on the last call know some exciting terminology build updates and action steps. Hamali is going to go more deeply into them on this call because this call is all terminology all the time. So we really wanted to show you the scope of some of those, the implementation updates. Then we are incredibly excited to have some very dear longtime friends of mine present on a collaboration we're doing to advance HCPS terminology for food services called Coding for Food. My friends Katie and Kristen. I've known these lovely ladies for a very, very long time because for those of you who do not know, I came into this work as a food insecurity subject matter expert in 2019. And then look what happened. I just stayed on. And then in the lens of IQR readiness, again, looking forward to the screening for social drivers of health measure and its requirements. What we're going to be working on this fall are some terminology assist to ready for reporting. And so I'll go more into that at the end of the call. Any questions on the announcements? More to come there on the agenda. All right, next slide, please. Next slide. So incredible. This is just general Gravity announcements. We have more specific announcements on the pilot page, but technical work stream is doing very exciting work. Of course, the STU 2.1 was published. So some really lovely HL7 collaborations and exploratory use cases. Really encourage everyone to go to the technical call on Wednesdays from 1 to 2. It's a growing and very applicable collective thinking about really important things in collaboration across the HL7 ecosystem. We had a really successful September Connect-a-thon, and we're looking forward to the January Connect-a-thon. Again, there was a lot of cross HL7 collaboration. The September Connect-a-thon, exciting things came of that. And then again, we're continuing that social care co-design session. We rounded the middle of it just recently and are closing out our last 3 sessions. We have learned so much from our social care friends. Really look forward to sharing what we've learned with you at the completion of that and having the greater Gravity community weigh in on some of the findings over the course of the fall and 2024 and beyond. Next slide. Next slide. All right, so this is us. This is the roadmap. You can see we're in an interesting building and dissemination and evaluation overlapping with coding for food and utility and security value sets, because we are actively building the terms that we voted on and agreed upon for digital access and digital literacy. We will be working on an ICD-10-CM submission. We are submitting LOINC instruments. We are submitting SNOMED CT terms. But while we're doing that, which is not entirely typical, we are also doing some exploratory new build and some work to kind of make use of this little fall session. Again, and then everything's happening over in the technical workstream I mentioned already on the previous slide, and ongoing work with pilots that we just had on the previous call, and ongoing work in the social care co-design work. So, and we're very excited to show you a 2024 roadmap. Next slide. Just want to note that this is what 2024 for terminology is looking like. Again, even though we're leaning into value sets for utility and security in the fall right now, they're going to be minimal value sets, and we'll talk about them very shortly. The true full domain build led by our subject matter experts will happen in 2024. We're also going to be answering the call from implementers to do more granular transportation and security ICD-10-CM to support the data requirements we're hearing that they have within claims, and kicking off the build work of our Coding for Food partnership, again, that Katie and Kristen are going to be talking about. And then the fall, we imagine the Coding for Food work possibly carrying on in the fall. And then other domains, new domain work to be determined out of the many things that we have on our strategic roadmap. Our governance committees, the strategic committee and the operating committee, are weighing through a lot of different things that we've learned are requested and important to the ecosystem at this time. So this will be filled out with those things that are identified and prioritized and funded as we go forward. Any questions on the roadmap? It's nice to have a 2024 roadmap to show you. This is, again, repeating, finally, we're back to our normal cadence. For those of us who remember the Wayback Machine, not even just too way back, we usually are January and February are quiet for quiet for building our terms with our terminology standard organizations and writing everything we need to put those consensus elements into production. And then we do our public work. And then in the summer, we do private work, and then we do our public work again. So there's this public-private cadence that we're used to so that we can do all of the extensive value set work and terminology submissions that we have to do for maintenance. All right, and next slide. Okay, any questions? Okay, carrying on, next slide. On to Hamali's Corner. I'm really honored to pass the mic to my friend Hamali. She's going to go through kind of a live demonstration of the of some of the work that the team has done in implementation assistance. All right, Hamali, go you.
Thank you, Sarah. So one of the things that Gravity has recently diligently worked on and contributed to, because the ecosystem very much needed it, is list of all the screening assessment value sets that Gravity has validated for 19 social care domains that we have worked on since 2019 till a date. So for each social care domain, we would work with the subject matter experts and identify the most commonly used screeners, federal level screeners, and those all are that all information is available at multiple places on conference, but we really felt like there is a need to have one repository where implementers can look at the list of all the screeners. Currently, there are 134 in one table, and you use multiple filters on that table to identify all the screeners that belong to a given domain, let's say food insecurity or housing insecurity. We also wanted to share with them what is the current low-ink encoding status for each of those screeners, so that they would know where we stand, whether it is current already in low-ink, or it is in submission to low-ink, or it is not submitted to low-ink. And so if there are any screeners those are not submitted to low-ink, but of their interest, they can take the initiative and submit it to low-ink. So basically, this is one of the, I think, intense effort that terminology team has recently completed. And this table is currently available on Conference for everybody to use. With some introductory information. You can also download this table as an Excel spreadsheet and look it as an Excel. Sarah B, who maintains our conference, has worked diligently to make sure that this table is live and interactive, and you can filter on basically individual screener if you want, or which domain. So if I have to search for food insecurity, it gives me a list of all the screeners which are in food insecurity domain. You can also see the low-ink status. So if I want to see if the screener is already in low-ink, if you filter on X, you will be able to see that these all screeners already has a low-ink code. It means that it is also available in our value set, because whenever the code is available, we make sure that associated value set in VSAC is up to date. You can also filter on multiple other tabs, which is submitted to low-ink by Gravity, or it is already identified as one of the key screeners that needs submission, and we are working on it. And the last column is not submitted to low-ink, but it is accepted by Gravity for a given domain. And if there is any additional notes on how to identify specific screener, we have the last column there. We have also worked on providing a reference to that screener directly. So if you click on that, you can actually open the screener and you can see that a screener which is related to that specific screening tool. I'm sorry, I'm a little bit having some difficulty speaking, but
You're doing an amazing job.
Everything that you need to know about screening instrument, that those are built by Gravity or accepted by Gravity, is shared in this table. And wherever possible, we have also provided the hyperlinks. There are some situations where the screener is proprietary or does not, does not have author's permission to share as a link. We have kept it as not hyperlinked, and it will. And we have also provided some instructions on why that is not hyperlinked for a specific screener. So I think this is one of the big contributions I think Gravity has made to social care ecosystem, where they can have easy access to most commonly identified screeners by Gravity team. So if there are any questions, we can always answer through chat or through email. But with that, I can pass the mic back to Sarah.
I don't know if you're gonna off the hook yet, Molly. There's some questions. So first of all, I want to just applaud the work of the terminology team. I'm the only one on camera, so every once in a while I see my face, which is like so proud of the work that happened to create this table. It really is an amazing shift. And one of the things I want to highlight is that it is the first table of its kind, right? So part of what Gravity does is work with our subject matter experts to ensure not just the most commonly used instrument, but the best instrument. And brief and available for clinical practice is available in our terminologies. So you know, not just the one item social isolation screener, but the UCLA loneliness scale, right? So not just, you know, an existent housing instability screener, but the Children's Health Watch housing stability vital sign, right? So there really was no clear way to see all of these single domain best in class questions and like represented comprehensively until now. And there was also no way for implementers to see what was out there comprehensively. We had individual domain level lists, but it would be very hard to see everything that Gravity has assessed that's either encoded in LOINC and not. So now that this exists, and it didn't exist until now, this can serve as the reference for policy guidance, for quality measure guidance, for all kinds of implementer guidance, because it is an exemplar of what we've done. The things that have been assessed as face valid by our subject matter experts, and the things that we've encoded in LOINC because they were high priority. So just great kudos to the team that worked incredibly hard over the summer to get this done. So we'll put we can put the hyperlink in the chat, but there's a section on the Gravity Confluence we made for this. So for years, all Gravity did was just create things, right? To instrument like terms. We're at a point now we're also trying to create resources for implementers. So there's a resources for implementers section on the Gravity Confluence navigation bar. This landing page is one of those areas. It's also available on the home page via quick links. So if you go to the Gravity Project main page, Sarah Bahal, the master of the Confluence, you can see it's in the for implementation quick link section. So if you don't want to have to even navigate, it's all right there. Yes, we try to make it useful, and we got to show it today to the team at Registry for the first time, and we all had a collective wow. So incredibly grateful again. So there's some questions regarding whether all of these tools have fire structure maps. No, they do not. And then great work, says Matt. And then Sarah Bahal says reach out for questions. I think any other questions on this lovely thing? Right now, the only people commenting on it, if you go to the bottom, are Hermali and I. I was like, it's beautiful. And I was like, it's beautiful. So if you want to go to the Confluence and comment on the work, you absolutely can. Any other questions on the instrument table? Okay, fantastic. And again, kudos to Hermali and Asha Emmanuel, who has moved on to NCQA. We're incredibly sorry to see her go, but she's still with us in our heart. And Sarah Bahal, who worked so extensively on this over the summer. All right, next slide. I just had the honor of presenting this to the Pilot Affinity Group. If you go to the next slide. And again, Hermali, thank you.
Thank you, Sarah.
The CMS Office of Minority Health had an opportunity to update their 2019 resource they had for Z-code guidance. It's best practices in Z-code documentation and existing SDOH Z-code terminology. And there's a lot of Gravity terminology on it. Forgive me for anyone who was on the previous call, because this is pretty exciting. Next slide. This is the pathways and guidance regarding what is Z-codes, why do we collect them, and then best practices for collection. And if you go to the next slide, this is the pictorial of all of the different Z-codes they're highlighting in the update. Everything with a yellow sun is Gravity created, right, through our consensus process. So it is massive. The orange one is one that was submitted by CDC, and so they led that submission, and we were, we bore witness to the submission. But everything else that's yellow came from the work that we've done together over the course of the last 3.5 years. So it's pretty amazing representation. I know, Kristen, I know. It is really quite amazing. So I know that when I saw this for the first time and started putting my little yellow suns on what was our work, it was pretty amazing. And I just want to note that part of our original origin story with Gravity was understanding the heft that social risks have in health equity and outcomes, and knowing that the capacity to represent them in claims-based analysis was really important. Like, if I couldn't send it to CMS in order to predict future risk for, in value-based healthcare partnerships, because this is Sarah, clinical practice, rural Vermont, then it was hidden in any projection of the acuity and risk of my patients, even though I knew it was driving the outcomes. So the fact that over the course of our 3.5 years together, we've created this much terminology to assist in assessing and understanding the stories of our patients and clients and neighbors is pretty amazing. So I got a bit misty. Very exciting. All right, next slide. Any questions on this, on the ICD-10 CM resource? It'll be on the Confluence soon. But anyway, kudos to all of you. And Linda, Hyde, I'm going to give you a little, and Tammy, a lot of our ICD-10 terms come through collaboration with what we call the council, the special council. So ICD-10-CM is such an intricate system taxonomy that we convene friends at AHIMA and the American Hospital Association to help ensure that we're getting our submissions correct. Our dear friend Linda Hyde, who used to be senior terminologist, and now Hamali is taking that stead, working with me, is now part of that council. So just a nod and thanks to our HEMA and AHA and Linda Hyde friends for helping us do this work so well. It is, Mike, it is really quite an impressive resource. I want to disseminate it with the little stars, though. It really makes it hit home. All right, next slide, please. Okay, next slide. It's very exciting. So I actually, for this next Coding for Food thing, I should have put the little "we are here" to the pre-work, because the point of bringing our dear friends at Coding for Food is to make sure that what has been happening, we have been working on this initiative in the background, Kristen and Katie, for at least 1.5 years, I think.
Yeah, like nearly 18 months.
I know. And then really the origin story for knowing that we needed new HCPS codes goes all the way back to 2019, when we tried to submit a new HCPS code out of our food insecurity work and did not yet have the use case to do so. So although the build for Coding for Food will likely happen in 2024, we wanted to take a moment to narrow the chasm so that everyone in the Gravity ecosystem can know what's happening out there in this space, and you all can be ready to dive in when we come back with formal build in 2024. It's my honor to introduce two of my dearest colleagues, and Katie Ettman and Kristen Sukis, who are going to talk about the Coding for Food HCPS initiative, so that when we come back in 2024, you're ready. Katie and Kristen, take it away.
Thanks, Sarah. Thank you.
This is just the timeline. So sorry. I should have not handed off next time. So my apologies. Hold on 1 second.
Yep.
Katie and Kristen, hold on. Next slide. This is an important thing to say before we go into Katie and Kristen's presentation, and my apologies. I've been talking a long time, so I forgot this slide was here because I was just talking since 2:30. You will note there is a shift in the cadence of our meetings, and this is for a really important reason. In our every other week meetings, our meetings directly overlap on top of the HL7 vocabulary work group, which has been meeting at this time for a very, very long time. And it means that we cannot ever have friends from HL7 vocab in our terminology meeting, which is sad. It's frankly just sad and not great. So we are asking the community to shift just 1 week. So we're going to do 9/28 and 10/12, and then shift our cadence by at 1 week, so that there's always something fun vocab happening in HL7 on Thursdays from 4 to 5:30, but it's vocab work group alternating with Gravity terminology, so that we can attend vocab as we should do responsibly as an HL7 Fire Accelerator, and they can come to our meeting, which they want to do, right? Does everyone understand what's happening there? So the cadence, 9/28, 10/12 every other week, and then we shift and we start at 11:02, and henceforward our meetings after November 2nd will not be conflicting with HL7 vocab. Any, like, stop the trains, that's not acceptable? Everyone kind of agrees that seems okay. All right, yay. So then you can see that we're just kicking off coding for food today, mostly focusing on utility and security value sets over the course of the time, and kind of lacing some other elements through for IQR. Now, next slide. Excited to present my friends Katie and Kristen, and I get to go off camera and just listen for a bit. Okay, go, take it away.
Perfect. You can hop to the next slide. Lovely. You've heard coding for food. That's us, or some of us anyway. So we can hop to the next slide. So just first, hi y'all, my name is Katie Ettman. My pronouns are she, her. I am the Food and Agriculture Senior Policy Manager at an organization called SPUR. We're a nonprofit think tank out of the San Francisco Bay Area. And I will let my dear friend Kristen introduce herself as well.
Thanks, Katie. My name is Kristen Sukes, and currently I work as a freelance food as medicine consultant. So I said in the chat, I wear a lot of different hats in the food as medicine space right now. I work on some individual projects focusing on state-based Medicaid, contracting and advocacy. And then I also lead some national initiatives and coalitions as well, focused on produce prescriptions. And then, of course, I've been engaged in the coding world and Coding for Food project, as Katie mentioned, I think for about 18 months now. We've really been kind of trying to get this project up and running. So we're really excited to be here today and talk to you all about this. I'll say, Sarah mentioned this before too. I have a history of working with medically tailored meals and FIMIC, which is where I met Sarah DeSilvi for the first time many years ago.
So, and we can hop to the next slide. So before we go into what is coding for food and the actual project, first we want to give you a little bit of background about how we got to this moment. So we can hop to the next slide. Which is, as we think about food as medicine or medically supported food nutrition or food is medicine or all of the different ways that we talk about integrating food into healthcare, there are a couple things that are all coming to a head, honestly, right now. In so many ways. So I'm just going to walk through these each briefly. So the first one here, I wrote huge policy changes because I couldn't help myself because they're wild. So the first thing to note, and lots of you probably know this, is that across the country, states are using federal Medicaid waivers, opportunities to adjust how they provide health insurance to low-income folks, to test and pilot new ways to give better care to the people who deserve it most. And so what that has looked like is places like California, North Carolina, Massachusetts, New York, et cetera, are all looking at ways or are already paying for food to help prevent, reverse, and treat chronic diseases. And so what this looks like is that we have lots of different bespoke solutions popping up to talking about and implementing these really important interventions. And so people are using waivers. In California, we use a mechanism called in lieu of services. There are just all of these changes that are happening at the federal and state level that we need to make sure that we are adapting to and pushing in the right direction. So that's one big piece of this. We're all moving towards the integration, but we're not quite there yet. The second that you'll see here, so actually I realized this is now exactly 1 year ago. So on September in the 20s, so like I think the 20th, not the 28th, we hosted a webinar where we were fortunate enough to have Sarah DeSilvi come present to more than 125 people, I think, about what is medical coding and terminology and what does this mean and why is it important? And that is because we all know it's important. The people on this call certainly know more than most, but I think lots of people get really scared and worried when they hear words like terminology and medical coding and HCPS and CPT. And so that laid a really great foundation for advocates and implementers from around the country. And then the following month in October, we had a mini summit of about 30 organizations who are like, yeah, we want to get down and dirty with what it looks like to integrate food in healthcare. And from that was born my next bucket here, which is we sent out an interest survey, sort of like word of mouth, talking about it at conferences, and said, hey, who would be interested in trying to work on defining these different food as medicine interventions and actually getting them integrated into terminology? And to this day, we have more than 60 individuals, nurses, doctors, food providers, et cetera, who have all said, yes, we want to see this happen and we want to engage. And so those are the experts who actually provide these services on the ground. So we are slowly but surely pulling together national partners. And then my last bucket here, which is about the national attention that's being paid to food right now. So we are now similarly a year out from the White House Conference on Hunger, Health, and Nutrition, which was a huge moment where the federal government said, hey, we need a full of government approach to what it looks like to address food insecurity, as well as our health in this country. And that momentum isn't slowing down. And so I pull all of these 4 buckets with you today because I'm like, there is so much happening. And I feel like we really want to make sure we capitalize on what's going on. And so we can hop to the next slide.
And I'm just going to add, Katie mentioned that we've been socializing this idea for a while, and the feedback that we've received outside of the survey from folks that have heard that we're thinking about this project, or maybe were at some of the conferences that we were speaking at, the feedback has really been, how quickly can you get this done? This is necessary. I'm a Medicaid director, or my state is asking me questions and I don't know the answers to it. And so it has really just fueled our fire to say, this is really important.
And so now I'm going to transition to something slightly more personal, which is, so I told you I live and work out of California. And so what you see on the screen in front of you today is a graphic that we came up with out of California to help describe the spectrum of different ways that people can access food. So like I said, we call it medically supportive food and nutrition, but we talk about medically tailored meals, which I'm sure lots of you are familiar with, RDN inclusion, but it's not always a meal. Sometimes it's groceries that an RDN helps you pick out. Sometimes it's a food pharmacy where you might be co-located in a healthcare place. So you're like, you have a clinic and you have food and you have wraparound services. Could be a produce prescription. So you can go out into the community and buy your own fruits and vegetables with a voucher. There are lots of different ways to do this. And what we found out when we put this out into the world is that we couldn't actually define all of these different ways of providing services. I want to pause. Sarah.
Katie, what is an RDN?
Oh my goodness, thank you. Registered
I just love this
dietitian.
because usually I present in food spaces about like terminology jargon, and now food people are coming to terminology spaces with food jargon. So please unpack your food jargon for the terminology people, Katie Edman.
100%. Yes. A registered dietitian coming in and helping you figure out what needs to go into that meal, what groceries are best for someone with a particular condition. And so what happened is we said, okay, our Medicaid agency said, yes, we are going to pay for these different ways to provide people food through our state Medicaid waiver. And then we can hop to the next slide. And California said, all right, we're going to start paying for these. You need to submit claims to describe these different ways that you're providing food. And you will look at this sheet here. So this is talking about HCPS codes, which I can't unpack that acronym because I never remember what HCPS stands for. And what you'll see here is that there are only 3 codes represented on this sheet here. And this is guidance from our Department of Healthcare Services here in California, who oversees Medicaid. And so this doesn't describe every intervention and the different ways people are accessing food through healthcare. And so this became a problem here in California. And as an advocate, I went, wait, other states are already doing this. North Carolina is paying for food with Medicaid dollars. So is Massachusetts. What are they doing to describe these different services? And how are we making sure that people get paid appropriately? And I think Sarah's going to help me out again.
No, there was just a really apropos question before you moved on from this slide. I don't want to, because Kristen already swooped in, but Amy had a really great question. Very, very again, I am loving the food people coming to the terminology people on whether or not, I've never heard of prescription for food. Is it a real thing or is it more of an aspiration? And then Kristen dropped in the Chipley document, which is fantastic. But I wonder if you can speak to that for a second, talking about like the heft of existent ways to prescribe food, which I am not going to talk about, even though I have a lot to say. I'm going to let the experts go. Okay, go for it.
Awesome. I'm happy to start. And then Kristen, if you want to jump in. So those are not aspirational. This exists on the ground. all over the country. So in a couple of different ways, I would say what is funny about this is, so for example, here in California, we have a local provider called Vouchers for Veggies. And so they work with clinics. And so an individual goes into a clinic, maybe you are a pregnant person with gestational diabetes, that qualifies you for the Vouchers for Veggies program. Your maybe nurse practitioner or doctor or whoever you're seeing that day at your visit goes, yep, you should be on Vouchers for Veggies. And you actually receive, in some cases, a physical paper voucher or a card that looks just like a debit card. So you can go out to any sometimes farmers markets or grocery stores or corner stores and buy your own free fruits and vegetables paid for through the healthcare system. And that's just one example that happens across the country. We're also really lucky that there's a long history of medically tailored meals being prescribed to folks. So lots of different ways and fits. But Kristen, I think you might be able to speak a little bit more to the national on the ground about what that looks like.
Yeah, I'm just dropping one last, one last report in the chat here, and I have plenty of more resources if anybody's interested in this. But Katie, while I was looking at those resources up to share with folks, I didn't hear exactly what you said, and so I don't want to repeat.
I used Vouchers for Veggies as an example and national MTM, but NPPC is where I feel like you could speak to.
Great, yeah. So we also have, I'll just say that there is a wide spectrum of food as medicine services. Katie, if you go back to your slide where you have the spectrum of services in California, that would be helpful. So the idea of kind of prescribing or providing access to nutrition interventions through the healthcare system is something that's been building for many, many years. It really started with medically tailored meal organizations who started originally giving medically tailored meals, very tailored, individualized, kind of home delivered meal packages to folks that have various chronic conditions, often folks that can't shop or cook for themselves. And originally the population that these interventions really served were folks who were dying of AIDS wasting syndrome and, trying to take antiviral medications that wouldn't work unless you were nutritionally sound. And so the idea of this kind of started there, and there's a long, long history, but Katie also mentioned produce prescription programs, which different than medically tailored meals. If you prescribe a voucher that folks can use at the grocery store to pay for fruits and vegetables, because we know that cost is the primary barrier to consuming adequate amounts of fruits and vegetables. And so I sent some resources. Those will provide just a brief kind of overview. There are examples from all over the country. I see some coming into the chat right now. California's list, which was just included in their 1115-1915 Medicaid waiver, is on this slide right now. So they have they have about 9 different interventions, I think you had mentioned, Katie, but other states have slightly different names for these interventions, which is one of the problems that we are faced with here. And yeah, Sarah?
No, you go on. And when you're done, I have something to add on. Yeah.
Okay. And then, kind of also going back to what Katie mentioned about these big policy changes, these programs are most places now across the country, and states are getting behind them and supporting them, so much so that they are writing coverage of these programs into their healthcare system. At the state level, that's really looking like Medicaid, but also Medicare Advantage, private insurance companies. So this is happening, but the policy changes mean that once these policy changes are happening at the state level, states are coming up with their own approaches. And what we have now is kind of, this patchwork of different approaches. And we need to kind of, organize ourselves and standardize ourselves so that we can integrate these services kind of across the board. Sorry,
the only thing, no, sorry. It's the only thing I wanted to add, again, the use case for why to create the terms is very clearly, I think that like Kristen just drove it home. But just to add one other element, Often these prescriptions are filling in gaps that are not covered by existing social services. So food stamps are not sufficient, school lunches are not sufficient, maybe the WIC is not sufficient, and patients are still suffering from poor nutrition, either from food insecurity or other causes. And then there's sufficient evidence in their effectiveness, and that's why they're getting reimbursed, right? So the research of colleagues like Seth Berkowitz on the role of medically tailored meals preventing readmissions and hospital complexity, the research of my friend Hilary Seligman on diabetic-associated food boxes tailored for diabetic patients at food banks, and the reduction in A1C measured at food bank visits, right? So payers go where the money is, right? And where the evidence is. So not only are these things actually happening, there's so much evidence that they actually work, right? To achieve the quadruple aim, which is patient outcomes and reduce cost, that the ecosystem just needs the terminology to support them. So I just want to add that one little thing. So it's not just everyone wants them. It's not just it's happening. It's that they actually worked to ensure better outcomes for patients at lower cost. And that's kind of the Valhalla of the quadruple aim.
I love that addition, Sarah. Right, we're so lucky to be surrounded by so many amazing researchers in this space. And thanks, Kristen, for dropping in some of the research compendiums. So we can hop to the next slide. I'll only be on it for another moment. So this was the California example. And so these are 3 terminology codes that currently exist. You will note this U6 here. So these are modifiers that California is asking its providers to use to indicate that these are services through a particular program of our waiver called community supports. And this is something that's only happening in California. So an S5170 U6 only means something in California. And so with that, we can hop to my next slide, which is me really bemoaning the fact that we can't continue to go with state-based solutions when the reality is if we want better data and patient care and truly telling people stories, that understanding and building consensus, that's where the real beauty and where this work can flourish. And so that's what we're looking to do here, to put together all of those pieces and go, all right, how can we actually do this work? So this was a lot of background, and now I'm going to pop it over to Kristen to talk more specifically about the project itself and how we're imagining it'll work. So next slide, and Kristen.
Yeah, thanks, Kitty. And just before I kind of launch into this project plan here, I do want to see if there's any other questions that we can answer. Okay, great. Send us on our way, Katie.
All right. Oh, next slide.
Oh, yes. Sorry. Thanks.
Oh, good.
Oh, wait. Are you controlling
It
the
is
slides?
not me.
Sarah's
No.
controlling it. Thank
No, it's not even me. It's the amazing terminology team. So just say thank you. You say next slide.
Thank you.
Amazing
Thank you.
Yeah.
Thank you, team. All right. So we talked a little bit about, the problem here. There's a lack of accurate food is medicine documentation. So these services are existing. They're being reimbursed by healthcare. We have no way to actually document them in the healthcare system right now. Katie mentioned those modifiers that California is using. Other states are trying to use other ways. There's no way to do it. And the current codes that exist are subpar. They don't actually describe the services or the spectrum of services that we have presented for to you today. That relates to, of course, the lack of healthcare integration. 2 of the common codes that are used for food-based interventions are here. S5170, home delivered meals, and then another code for meals per diem as well. And then Katie mentioned the rise of the state-based solutions and bespoke solutions. So kind of what do we do about this? Well, we want new HCPS codes for food as medicine interventions. We know that we're going to need a lot of codes that kind of describe how folks move through the healthcare system to get these interventions, and the labor codes and everything. But our first step is to really work on defining these services and defining these products that are given to folks. And so we've recognized with Sarah's help that HCPS is the best place for this. So in order to do that, in partnering with Gravity, we really know that we're kind of coming in. We have a lot of the relationships with subject matter experts in the field. And so our role is to bring these folks together under all of the different umbrellas, which I'll talk about later. But we need to bring these folks together and we need to reach consensus around a set of deliverables for these food as medicine services. So we also, in doing that, of course, are working in partnership with Gravity to support our end term goal of building HCPS codes. And then, of course, while this is happening, we also know that it's a major goal to stay coordinated with other folks working in this space. I mentioned before the labor codes. There's a whole nother group working on just labor codes, for example. And there's another group that's working on implementing new codes. And so we need to make sure that we're staying coordinated. So what this looks like is in the fall and the winter right now, we are still kind of planning, getting our ducks in a row. We're coordinating with partners, and we're also securing funding. Part of that planning right now is building out our advisory committee, which I'll talk about on the next slide. And that is about 95% complete. We feel very excited about this. And then we have just a couple other slots that we want to fill with other representatives too, which I'll talk about. In the spring, that's when we'll start to launch phase 1 of this work. So we are going to be focusing on creating HCPS codes for a series of food as medicine interventions. And so phase 1 actually takes the food as medicine interventions that are closest to reaching consensus around definitions. Medically tailored meals, for example, already has a definition that they've reached consensus on. So there's just a couple other gaps of information that we need from that group in order to kind of move on to the code building process. Then we have medically tailored groceries, which are is an intervention with a registered nutrition dietitianist that is not a meal, but provides tailored groceries for an individual. And that group, the group of interventions, is also extremely close to reaching a consensus around a definition. So again, similar to MTM, they just need a couple extra elements for the deliverables. Then we also have produce prescriptions, the third food as medicine intervention that's kind of the most advanced here. And so there's a national produce prescription collaborative that has a nationally recognized definition. We just want to make sure that we're inviting everybody to the table to really agree on that definition before following up with some other deliverables as well. And lastly, we have this very broad category called nutrition supports. Nutrition supports, folks, generally it includes things like kind of behavioral, like education. We have cooking classes. We have even like cooking equipment. All of that is these additional things that are given in addition to food interventions. And so we recognize that we have to start organizing that category, and we need to bring folks together to figure out what actually is included in that broad nutrition supports bucket. So that will just be a planning phase for this group. No codes are going to be made right now. And then spring 2024, we'll be launching phase 2 of the work groups. And those are the rest of the food as medicine interventions that are a little bit kind of, I don't want to say behind, but up and coming, and they don't really have, they haven't reached consensus around definitions yet. And we'll also be regathering those nutrition folks now that they've laid out kind of what types of services are in that bucket. Lastly, the column on this page is about deliverables. And, I've mentioned this a couple times on this slide, but what else besides definitions are we really focused on getting from these subject matter experts? Well, we know that we need a literature review to kind of make the case for this and show the need. We also know we need a very clear comprehensive definition. Sarah DeSilvia has been very clear on kind of what that needs to look like, the what, why, where, who, when, everything. Why is it this, not that? And so she will be our guide, and the Gravity Project will be our guide in making sure that we are doing that appropriately. And third, we also need a description of the pathway to service. So how is a patient actually working its way through the healthcare system before the provision of service? So how do they get enrolled in these programs? And then lastly, we need a list of subject matter experts so that CMS or anybody else in the code building process can go to them to ask any questions. So that was a lot to take in, but that is a very broad overview of our work plan here. Sorry, next slide. Thank you. So our coordination and partnership, this is a partnership between basically a bunch of us and kind of an amorphous group of food as medicine providers from across the spectrum. I'll note this is a very big deal project because it's the first time that food as medicine providers, medically tailored meal providers, food pharmacy providers, produce prescription providers, you name it, it's the first time anybody's coming together to work on one initiative. So this is really cool. We also have a Coding for Food Advisory Committee, which I will be talking about next. And then, of course, I mentioned those external partners, the ones working on labor codes and the ones working on implementation. Next slide, please. So we have really Sarah, Katie, and I, as well as other subject matter experts and leaders in the field, have put our heads together to think about kind of who should be leading in this work, who should be in the room, what kind of representation do we need to do this well. And you'll see here a long list of folks, but we have representatives from leading community-based organizations and food as medicine providers from across the country, like Syria's Community Project, Food and Friends in DC, Project Bread in Massachusetts, the Teaching Kitchen Collaborative. We also have these big national organizations like Feeding America, there's somebody else in there, Academy of Nutrition and Dietetics. Then we also have the National Produce Prescription Collaborative. And then we also have the Food as Medicine Coalition. And then we also have these kind of technical assistants and policy experts too, like the Center for Health Law and Policy Innovation, as well as government representation, like the Centers for Medicare and Medicaid Innovation. We do know, I mentioned this is about 95% complete. We do know that there's a couple seats that we would like to fill. Namely, we would love to have a healthcare partner in here, at least one, for example. And if there's anybody else that you think we should make sure that is represented on this advisory committee, we are all ears. We would like to make sure that this is comprehensive as possible. And I think that might wrap up our intro to the project. So we're happy to take any questions that anybody may have.
I'm just going to say I'm thankful. What we recognized was a need, again, to bring this work that, I've been, if you can imagine two ecosystems converging until this moment in time, right? So for over the last, 4 years, it's been like me doing outreach to the food space to kind of ensure that the use case is established, the why is established, the path forward is established, and then we've always done our work over here, and a lot of these questions were raised in our 2019 build, and I even put that in the chat. So Linda, I'm sure you remember, working with the amazing Tina, she's back, right? Academy of Nutrition and Dietetics. Tina's taking lead and not Donna, who was the lead SME at the Food Insecurity at the time. But a lot of our friends from Food Insecurity are back. So I'm just really grateful for the two of you to come and present because it was time to bring everything together again. You got some kudos in there. Any other questions before we switch to the rest of the deck? Look, I know, applause to the excellent evidence-based, lovely presentation of my dear friends, Katie and Kristen.
Thank you.
I
you all so much. You're also welcome if you don't have questions right now. Like, we are ready here, happy and able to continue to chat. So do not hesitate to reach out. And Sarah knows how to reach us in multiple.
I've been having lunch with these two lovely ladies most weeks for a long. Corey, hi.
Hi.
Hi,
So I
buddy.
didn't mean to interrupt you. Yeah. And Sarah, I don't mean to, I probably asked you this question offline, but we just want to throw it out for the broader community as well. This is all great. Thank you for the presentation. But, thinking about codes, not only for, programs or a specific kind of meal, but thinking about the services and more specifically, the differentiation between services along sort of labor lines, the amount of work it takes to deliver different services. And I'm not sure of good examples in food, but certainly, Sarah, you could rattle some up. I think about it in terms of transportation, for example. A ride is not a ride, is not a ride, and there's very different labor considerations. I'm wondering if that's where we're thinking about that, or how that's thought about in food. Maybe that's a good question, is in the food space. Is there anything we can say about that?
Do you want me to try, Katie or Kristen, or do you want to
You can try and I can fill in too.
How about you start and then I'll do terminology nerdy stuff at the end.
Okay, great. Corey, you bring up a really good point, and this is definitely something that needs to be addressed as well. And I think you can kind of look at it at two different ways. One about a holistic kind of price point or cost for these interventions. And what I mean by that is medically tailored meal folks tend to have a cost per meal, and they embed the labor that it takes to create the meals and deliver the meals like in that price point. And then you also have like the labor it takes the medical care team or anybody else involved to kind of make this work. And that is where, you need like the medical documentation, I think, of that happening. And the other thing I'll say about that is the Partnership to Align Social Care there is a billing and coding work group that is specifically focused on labor codes. And they're the ones that are really working with food as medicine providers to work out that question and kind of think through, where does that labor live? How does that labor get documented or show up? And how does that labor get paid for?
I'm just going to add the nerdy terminology bit to that. So currently in the ecosystem, so there's different types of things to account for in cost, right? There's labor, right? But there's also units, right? So units of X. And so one of the things that creating this terminology will allow us to do is apply existing methods for quantifying units with different kinds of modifiers, because at least there will be a standard HCPS code for X. And if we want to do, different levels or units of a produce prescription in time to capture different depth or complexity of those things, we'll be able to do that because we'll be applying one HCPS code and one type of modifier, as opposed to multiple types of modifiers, one for the HCPS code, one for one modifier to define what the actual HCPS code stands for, so we don't have the specificity, and then another modifier to describe units in complexity. So there is a capacity, once we establish the HCPS term, to use existing modifiers to describe some of the complexity of the thing given, not just the labor around it. Corey, is that helpful?
Yeah, I think I'm just gauging I'm happy to hear we're thinking about this, and thanks for the responses.
And you know this well because of your AMA work, of course, I think, right? I'm putting you back on the spot, yeah.
Yeah, I just think, I don't know what the right answer is, but I know that it's important, whether our world evolves on the social care side into a fee-for-service model or value-based model, accounting for care and the cost of that care is critical. And I think there needs to be a systematic way to do that to move us forward.
Wonderful. All right, any other questions? All right. Oh, and then one thing, so Tom, you asked, but health clinicians can be using these codes, but we think in lieu of services is another really great example how the absence of HCPS codes really limit, expansion of programs, right? So if an entity is documenting within lieu of service and Medicaid allows that now, if you have a relevant IC10CM code and employ these novel HCPS codes, then it wouldn't just have to be a clinical entity that would be reporting it into claims. It could be anyone that could testify to the reduction in cost over the course of the 3-year term, right? Which is what I think in lieu of services has to apply to. And this, again, the great thing about these food things is they're so well studied, is the evidence already says that they reduce cost, right? So medically supported groceries reduce cost, MTM reduce cost of admissions. So it's going to be really great to provide the ecosystem the terminology they need to comply with ILOS in granular ways.
Yeah, and I spy 2 more in the chat, and one of these to being, can this then get reimbursement to CBOs? Yes. So that is exactly what we're trying to make sure happens in California in a more streamlined and trackable way. And then at the encounter level, I think it depends on, so this question from Eugenia, who completes the codes at the encounter level, the provider. In my head, and Sarah, please help me here, I think it depends on who is providing that service. So for example, if the provider sets forth a referral, they might use a code that goes, oh, I screened someone for a particular condition, I've referred them here, and they might need to document that. But it is very possible that the actual community-based organization providing, say, the meal is the one actually using these HCPS to then submit a claim to the health plan. So it depends on the flow the patient goes through, who's going to prepare that information.
Great. Thank you. That's really helpful to begin to get an understanding. I'm working with several CBOs that are trying to prepare themselves to deal with this, and some of them have gotten the response, well, that's what you're there in the community to do. So no, we're not going to pay you. We're just sending you more referrals, and you should be thankful for that. We're all kind of tired of that.
No, definitely not the goal here. The opposite.
Great.
No, you go. I mean, Eugenia is asking some really good questions. I think we do want to segue to the other part of the agenda. And the good thing is this group is coming back in February to build with us. They also can come back later, but I do want you, because these are actually really exciting questions to answer, because but you want to answer a few more?
Real quick, I can finish this last one.
Very
exciting. I will always come back.
I know.
Which is, oh my God, you're reading my mind. So I'm working on implementation in California right now. We have small CBOs who are not prepared to deal with the medical system. And so we are exploring hub-based models where there is someone, an organization, maybe a nonprofit or another provider who actually holds the primary contract with your healthcare payer, and then subcontracts. And so they've actually set up situations where people can then prepare an invoice, and then that lead entity or that hub actually submits those codes and deals with more of the medical infrastructure. So that's one way to do it. Other organizations are working through for-profit entities who will also handle that. So we're trying to come up with intermediaries, as well as teaching some of our community-based organizations who are interested and excited that they can do this, that they can be sophisticated enough. It's just a learning curve. And so providing some of that technical assistance. So I'd go a both and. To be able to handle all of those things.
And I just want to note, I think that was, and again, I just got on my soapbox, I'm now going to get in again before I pivot. The requirements to do this is already happening, right? So the terminology that's being created is not creating, it's not creating an incentive, it's addressing demand, right? Because they're already required to do it in North Carolina. They're already required to do it in California. They're already required to do it in payer partnerships. They're already required to do it because of in lieu of services. They just do not have the data to do it well. So not only is there technical barriers and exchange barriers, there's also just semantic barriers. And luckily enough, we're able at Gravity to lead into those gaps. Like what we do is say, you don't have terminology to name the things you're doing that are aligned with the evidence. That is our job, to fill them. Right. And then, so the good thing is this is already happening and we're just going to be creating the language. Great.
Thank you for letting us go over. We really appreciate it.
Yeah, no, this is, it's so exciting to finally, and I'm sure my friends in the terminology work stream, now they know, like, because I've been talking about this for a very long time. So you guys are welcome back. And the thing is, if the community wants them to come back and present again, we can absolutely have that happen. But again, we're trying to get the funding to kick this off formally, and funding and a few more placements of technical experts on the advisory committee to kick this off in 2024. Whew, okay. Now we know, Molly. I know. Okay. Next slide. I'm going to quickly go through these next slides just to get us to the bottom of the hour. Again, we have this mini sprint that we're doing between now and just like early December when we sunset for the holidays, and to go into and we race to submit IC10CM and all kinds of other requirements. And so we're trying to make the best use of it and really leaning into enhancements for ready for reporting for inpatient quality reporting coming in 2025. Bye, Katie and Kristen. We appreciate you. Sorry, I'm racing.
Thank you.
Bye, friends. Again, they are very, very dear friends of mine, so it's nice to have them here. So someone asked earlier about housing and transportation. So when you look at the requirements for IQR, I'm going to go through them shortly. There really is one critical gap and one opportunity, and you will go through them in the next few slides. Next slide, please. This is, we're calling this utility and security value sets kickoff. So basically the context is in January 2025, the IQR inpatient prospective payment, screening for social drivers of health, and screening for positive for social drivers of health measures and reporting. And I wrote that 2025. I got none of my dates right. That's 2024. Today was a slide day and I got my dates wrong. I'm so sorry. January 2024. So Gravity is leaning into ensuring our value sets and guidance meet implementer needs, because we're hearing from our member implementers that that you need resources to address this driver, and we want to assist with it. Thank you. So sorry. I know I should. I mean, I'm a CMS employee. I should know. I should know. Just as a disclaimer, I am hired by CMS to work on the revisions to IQR with another hat of mine. So I love that I got the date wrong. My apologies, CMS friends. So the domains of reference for the screening for social drivers of health measures are aligned with the Accountable Health Community's health-related social needs screening instrument. They are food insecurity, housing instability. That's what they call it. Within housing instability, it's inadequate housing, homelessness, and housing instability. I'm working with CMS on fixing that. Transportation needs, and then utility insecurity, utility difficulties, and interpersonal safety. So those two bolded areas are areas where we don't have necessarily all the guidance we need to assist implementers for 2024. So specifically for utility, we're going to talk about that next. We have beautiful granular value sets for screening instruments and for every other element. For all of the other ones, it's just these two that are highlighted. Next slide. So current opportunities, like things that we are leaning into right now, is build. Even though we have utility and security build on our roadmap for 2024, we have a lot of existing terminology within our material hardship and financial insecurity domains that are the base of a good utility and security value set. We've been doing this for 3.5 years. We talked about utilities within material hardship and financial insecurity. So there's programs and resources and conditions in there that can form at least a base set. So we can say, if you are trying to do utility and security implementation, this is what Gravity can offer you now. Not perfect, but it's what we can offer you now. And then the great thing is, as we do utility and security build in 2024, we can glean, refine, and curate and amend it. So our focus right now is to try to make sure we can assess our material hardship and financial insecurity value sets and create something ready for the ecosystem in 2024. Does that part make sense? And this is what the ecosystem is doing right now, but just not in a standardized way. If I'm an implementer, I'm racing to do just this right now. And this is gravity leaning into a standards-based solution. We good? Okay. The other thing that we're thinking about, again, hearing from the ecosystem, and this is consideration because it doesn't actually require a ton of more labor, is guidance how to align the interpersonal safety screening with gravity evidence. And I say this because we have all of our, when we approach concepts of interpersonal safety, which include elder abuse and intimate partner violence, the evidence led us to having specific value sets for those things. But that's not the way the guidance says to address it in the measure. It says interpersonal safety. So implementers are kind of confused. We don't see this as, if we lean into this now or lean into this later after 2024, this isn't new build per se. It's just leveraging the same subject matter experts we have, Lisa James, Chris Grasso, all of our amazing subject matter experts in elder abuse, which was the panel of brilliance, just to create, like if I were thinking about it from an evidence perspective, this is how I'd approach interpersonal safety in order to align with gravity terminology. So that's something we're considering as well, because certainly our friends in the ecosystem were asking for it, and our SMEs are right there to assist. Any questions on that? It's really just kind of wrapping the interpersonal safety questions in the HC instrument or in any instrument with pre and post guidance on how to get to gravity value sets. We good? Okay. And again, this is all listening to you. Next slide. So IQR enhancement specifically for the value sets, we're going to be analyzing to glean those utility and security terms into initial master lists for consensus approval for 2024 use. I kept on getting those dates wrong. I kept on thinking of USCDI, HTI1. This is the problem that comes into reporting in 2025. I was getting my years mixed up there and my regulations. And then again, full utility and security build happens in 2024. Well, we'll start popping things in. I want to note that the fact that the ecosystem's asking for this, of us, I've been talking for a long time today, just goes to show how important our standards are. So there is a social determinants of health relative policy requirement coming down the pike. They want us to help them solve it from a data perspective. And I really appreciate that. That means that, you know, everyone knows that this is our job to help give guidance on these things. Next slide. I think that's it. So next meeting is 2 weeks from now. But then after that, we're going to start that cadence where we flip in order to give alternating weeks with the HL7 vocab. The calendar in HL7 will be up to date and correct. So staying the same time, though, always Thursdays from 4 to 5:30 Eastern Standard Time. Join the technical call on Wednesdays from 1 to 2. Pilot work stream is the last Thursday of each month, 2:30 to 4 o'clock. That is going to have 2 more sessions in October and November, and then take a winter break and likely come back in 2024 as well. So Eugenia, you have a really good question. Those same subject matter experts who are advising us on approaches to interpersonal safety are really lovely to ask questions of on that topic. And we might just bring them to this meeting to help. Again, this is all very much IQR related, so we can bring them to this meeting to help in real time. I also want to note that one of our pilot sites with Gravity has an IPV use case that's coming out very shortly that Lisa James, one of our subject matter experts, they have a blog coming out that she participated on because we're just leaving Domestic Violence Awareness Month, which is September. So there's a lot of relevant things there. But I think if you, Dr. Hens, if you just, I think mostly I'm going to hold space for that and think that what we can do in this little sprint is bring Lisa and the subject matter experts back to help us work through some of those guidance questions. You also can email the question directly to us at gravityproject@hl7.org, and we can send it to our amazing friends. Because part of being a subject matter expert at Gravity is that you're never off the hook. You're family, and then we ask you questions forever. So Tom, unfortunately, Tom, Sarah Bahal is the master of our Confluence page. There was a I think Sarah might have, so Tom, if you write an email with that question, we can forward it to the right person at HL7. There was an error in the privileges on the Confluence that I think we fixed that looks to be something different. Yeah, but if you send us an email, we can forward it to the right people at HL7 to help. You shouldn't have to log in to see anything on the Confluence. So that was a privilege thing that we fixed about 6 weeks ago. There was an error there. If you write us the problem, we'll help you. Any other questions before we go? 5:19. Incredibly grateful for you all. See you in 2 weeks where we talk about utility and security and trying to rope in other elements for IQR readiness. Kamali, any closing thoughts?
This is great, Sarah. I'm very excited to hear about food for medicine and subject matter experts. So exciting for us too.
I know. I'm excited too. And we look forward to seeing you in 2 weeks. And thank you so much. Bye, friends.